Okay, y'all ready? Let's see. We're going to be looking at causes or the nature of behavioral emergencies and psychiatric emergencies, emergency care for them, and then also we're going to look at suicides, potential suicides, because that's the problem we see. Those will be more of our patients. Once they've had suicide or committed suicide, they're not really our patients anymore. We just call it. We're going to look at how to handle aggressive and hostile patients, patients that don't behave well, how to restrain a patient, and then legal considerations, and there are several. Sometimes you may have a patient who is behaving in a dangerous or aggressive manner. It may be dangerous to you, it may be dangerous to people around, or it may be just dangerous to themselves if they want to hurt themselves in some way. Things that can cause behavioral emergencies, I guess we probably should have defined a behavioral emergency. A behavioral emergency is going to be one where the patient acts in a manner that is not acceptable to social norms. It's not acceptable to the people around them. It's not acceptable to society. So some of the things that can cause that, of course, is stress. When you look at the amount of stress that people are under these days, it can cause some behavior problems. Physical trauma or illness. What can you think of an instance of physical trauma that could cause behavior changes? Absolutely, head injuries. And sometimes it's hard to differentiate. Could they possibly have a head injury that's causing this? Or what else could cause some very unusual behavior?
Excessive blood loss.
If they're hypovolemic, you mean they don't have enough oxygen to the brain? So it'd probably be hypoxia. Hypoxia could cause that. I'm sorry?
Hypoglycemia.
Yeah, hypoglycemia. So there are quite a few things that can cause behavioral emergencies that are not based in a psychiatric issue, but are physical or medical issues. So you're going to have to be able to look at those and see if you can decide the source of those. Drug and alcohol abuse can cause behavioral emergencies, and of course different psychiatric conditions can cause that. See, I went on to tell you this. A behavioral emergency is a manner in which a person acts or performs. That's behavior. Abnormal behavior is unacceptable or intolerable to the patient, family, or community. So that's terminology you need to be familiar with because you may see it again. So make sure you recognize what that is. Behavioral patients, they're going to have some form of altered mental status. And I think we kind of touched on these the other day, didn't we? We talked, was it another class about behavioral emergencies? It must not have been this one because we're just not getting to it. Sorry. There are a few psychiatric conditions that you're probably familiar with, right? Do any of these look familiar? Y'all ever know anybody with an anxiety disorder, where, besides just claustrophobia, but can't get in their car, can't go somewhere? Do you know somebody like that? Is it you? It's not you?
Oh, you know how we talk about auras? My mom today got me every even saying the word aura, so she was having one.
Yeah?
Because she gets migraines, and she said she had migraines.
Yeah. Depression can be a psychiatric condition. Bipolar disorder. Anybody got any bipolars in their family? Nobody you know though.
No, my grandmother had it.
Yeah. Schizophrenia. I mean, there's lots. But as I mentioned before, you've got to try to examine if there to determine if there are any physical causes or medical causes. And these are just some non-psychiatric causes of altered mental status. So the patient presents with altered mental status as part of their behavioral emergency, but some things you can fix. If they're hypoglycemic, we might be able to fix that. If they're hypoxic, we might be able to fix that. Probably can't fix a stroke in the field, but it's possible, if we get them to the hospital in time. We talked about stroke the other day. What's the window for receiving fibrinolytics?
3 hours.
It's 3 hours. Okay, good work. Who could not get fibrinolytics? Who should you not give fibrinolytics to? Good thing that's not a test question. I told you guys this the other night. Yeah, anybody that has any type of blood clotting issues for whatever. Sure, if they are on a lot of blood thinners, and they're not going to get extra blood thinners. Anybody that's had major surgery recently, Anybody that would be a threat to have a bleed. We said the 3-hour window, and the 3-hour window is important because why? If it's been 6 hours out, what happens? Yep, beyond that you've got infarcted tissue. What's the difference between infarct and ischemic? Ischemic is injury, infarct is tissue death. That's right, okay. Patient with head trauma, we're not going to fix that, but we can recognize that as a something you can identify what it is. Substance abuse, hypothermia, we can fix hypothermia, right? Sure. Might be able to have some impact on hyperthermia. So there are a lot of other causes of altered mental status. And you know, altered mental status doesn't mean you're unconscious. It just means basically you're having a behavioral emergency or whatever. You know, or not, well, not the true definition of that, but you're not acting right. Cause of behavioral alteration, said these: low blood sugar, hypoxia, hypoperfusion, head trauma, mind-altering substances. Remember we talked about those the other day? What do we call those? Mind-altering. Like the, yeah, hallucinogenics would probably be the one you most think of. Psychogenic, this is going to be resulting in psychotic thinking. For psychotic, you've got somebody that really has had a complete break with reality. For depression or panic isn't a complete break. Hypothermia, hyperthermia, meningitis can cause altered mental status. Seizure disorders, toxic ingestions, drug withdrawal, alcohol withdrawal, all these can cause, is there an extra one? Yeah, alterations in behavior. So don't just automatically assume if you got somebody that's acting weird, you know, don't just automatically assume that they're just psychotic or something, or they're having some behavioral emergency. More times than not, there is a diagnosis there that you can figure out something specific that's going on with them rather than a behavioral issue. Situational stress reactions. Sometimes we freak out over normal things, right? Mm-hmm. I had a student in my office this morning freaking out over a test. Freaking out. It was stressful, I guess. We all have tests. Fear, grief. Grief can cause you to act not in a good way. Anger, also. You ever been so mad you did something you were sorry for later? Or if you actually did what you were thinking of, you did something later. Yeah. I hope that if you guys are stable enough that you're in class, you're motivated enough that you're not going to go out and do something really weird if you get mad. But all of those things can cause a form of altered mental status in that you have some strange behaviors. Okay, if you've got a patient that's not acting right, particularly if you think it is a behavioral emergency and it is not hypoglycemia or something like that, it's important that they don't feel boxed in or threatened in any way. So you don't want to rush them. This is the patient you may spend a lot of time with. You know, if you get a respiratory distress patient, you know, you're going to get them on oxygen, you're going to transport them as soon as possible. For a patient having a behavioral emergency, you're just going to crank that down and take your time to work through it. If they feel threatened, then they might give you a reason to be threatened. So tell the patient who you are and what you're there for. You know, I'm here to help you. Tell me what you need. How can I help you? You need to be calm and not get freaked out. You know, right now it sounds like we're talking about somebody that's just weird, but you may have a patient that's angry. They're, you know, even if it's something like they've lost a loved one and they're angry about that. They can act very badly. So it's important that you're calm and that you listen. You know, I know I've said this before, you got 2 ears and 1 mouth, so you should listen twice as much as you talk. I could teach them. Never mind. But yeah, you need to listen to your patient because they'll tell you if they feel like you're listening to them. They'll tell you what's going on. And that cuts across all of your patients, you know, particularly your medical patients. You'll find that when you transport patients to the emergency department, many times they will tell the staff there are things they never told you. And the reason being is you're running your mouth and not listening. But if you'll be patient and listen, they'll tell you what you need to know. So take the time to listen. Be honest with them. You know, they ask you questions sometimes and You may not exactly know how to answer them, but answer to the best of your ability. You know, don't tell them anything that's not true, but don't scare them to death either. You want to be reassuring. Stay alert for changes in their behavior. Hopefully, with your demeanor, you'll be able to calm them down and have them be more compliant, so they will permit you to transport them. But be alert to changes in the opposite direction, most particularly. What types of things might you think that you might see if they are changing in a bad way? Yeah. You can see their muscles tensing in one way or another. It could be, flexing of the hand. It could be, the jaw moving. What other things might you see? They won't keep eye contact with you. They start looking around or darting around. Yeah, they may get voice inflections. Usually, as stress sets in, it usually does go a little bit higher, or they talk faster. They may start moving around. They may stop communicating with you. So yeah, it's one of those things that would be difficult to say, these are the specific things you're looking for, but as long as you remain alert, you will pick them up probably without even noticing specifically what they are. Excuse me. Okay, presentations. They may present themselves in a lot of different ways. These can be very complex things to try to sort out. They may be withdrawn, where they won't speak to you. They're just almost catatonic. They're in a corner somewhere, sitting in a chair, and finally somebody's called 911, and they won't talk to you. They may stare at you. They may stare off over your head somewhere. The flip side of that, they may be very talkative. I mean, they're just like, I know people like that, and they're not really having a behavioral emergency. But they're very agitated, and they talk sometimes, and they're not making a lot of sense. They're just jabbering. Or they could have very bizarre or threatening type of behavior, where either to injure themselves or injure you. Now, if you see that, what are you going to do? See ya. Yeah. And of course, if they want to harm themselves or others, those are never good. General rules for interactions. Make sure that you tell them who you are and why you're there. What your job is. Now here, you can see from this picture, they are planning to take this girl down. Now, anytime you have to restrain, that didn't sound good, did it? Anytime you have to restrain a patient, it's important that you have law enforcement there. We're not trained to wrestle these people to the ground. However, oftentimes we may have to transport them for their own, well-being. So in this case, they're going to try to calm her down. And how calm would you feel like that? Surrounded? Not so calm. So, I don't know. I've never really had this work. But so anyway, speak slowly, clearly. Make sure you maintain eye contact. Why is maintaining eye contact important? Well, they know that you're paying attention. Yeah. What does it do for you?
It makes you stay alert.
Yeah. It lets you see right away if they've got some action in mind or they're starting to change. So as long as you keep eye contact and you're looking at them, you're going to be alert to changes in their behavior. Listen, of course. Don't be judgmental. Can't act like the parent thing. Well, if you didn't do all these drugs, then that just never works. Keep an open, positive body language. Don't march up here like,
Right.
Yeah. We're here to help you. We don't want to hurt you. Did I post that discussion question on y'all's board? I don't think I did, about weapons for EMS. I should probably do that. I did it for the other class. They were talking about whether we should be armed or not, whether we should carry weapons. After we had that hostage situation or shooting in North Atlanta and then one up in New York recently. But anyway, that was kind of interesting. I might just post that so you guys can talk about it.
Mine doesn't.
All guys carry knives, don't they? Don't they carry, carry a knife in their pocket?
One of the paramedics looked up the store, which it was all over the paper. In the range, the paramedic was on the scene of the fight. And this man, he got in a fight with other transformed to the broke dog. And then he just went crazy in the back of the ambulance.
The patient?
The patient. And he started beating up the paramedic. The paramedic pulled his knife out and cut him.
Yeah.
And then some ex-girlfriend or something jumped in the back of the ambulance and went crazy. Well, she got cut in the middle.
feel covered, John, in that? I'm not gonna ask girl, Jen,
I think it's more, honestly, I think it's more important that a girl carries a knife versus than a guy. 'Cause
Oh,
as
so
a
I get
guy-
stabbed with it?
Well, no, just, I think
No, man,
girls,
girl ain't got
I
nothing.
mean, as a guy, it's just the point of, it's true, guys have stronger defense bones, they're typically stronger and more able to handle themselves. Girls kind of need something to, like, I'm gonna get my little sister a good knife for her birthday for her to carry, and there's no reason she has to tell you when
Just
she
give me
has
some
it.
brass knuckles, I think I'm better.
Brass knuckles are awesome too, yeah.
It's like
I'd
a
rather
roll of
carry a
quarters.
gun.
If you put a roll of quarters in your fist, it'll feel like a brick.
Carry
It's
that.
like,
They
Yeah,
make
but I'm still gonna
dangerous
break my
weapons that
knuckles.
only go right around the lips and fingers. It's-
Anyway, it's a great topic of discussion. I checked with our, our state EMS office recently because I didn't realize that we actually could choose. There's no rules about EMS providers not carrying weapons or not. There's nothing there that says. Now, each individual service may set rules, so, if that service says you're not to be armed, then you're not to be
you still
armed.
can't
So
get away with like
it's
jumping out
individual
of
thing,
the
but
with an AK, like.
Yeah, well,
Right.
that's
with that
something
can
like
come a lot of
carrying-
problems. So.
Carrying your concealed
Okay,
weapon.
yeah,
Like, if
concealed
you
weapon,
have your
yeah.
concealed to carry, and they say you can carry it, I think you should.
Yeah, well, and that's something we can talk about on the board, but as far as us, we need to look at our own personal safety. And, if they know you have a weapon, all of a sudden you're not so safe
Yeah, I mean,
anymore.
that's the main thing. That's why it's probably it
Well-
stresses them out more if they see a
But
weapon.
if they
on
know,
you,
if
than
they,
just-
it's kind of like, in any house in Alabama, probably 80% of the time, somebody's gonna have a weapon in there. So there's probably a pretty good chance. If you're breaking in here in this state, you're gonna get somebody with a weapon. But with EMS, you don't expect
Yeah.
us to be carrying weapons, we're not law enforcement. So if word gets out that, we may have weapons, and they're gonna start expecting we have weapons, and they're gonna act differently.
Maybe
But
they call
anyway.
911 less.
One of the points, one of the points here is, it's important that you stay calm too, so that you don't, we're human beings, and if we feel threatened, then we're gonna respond, in a normal manner. So sometimes we have to kind of fight that urge to respond in a calm, non-judgmental manner. It's important that you try to maintain your patient's private space. Every culture has their own, what their private space is. There's some ethnic groups, they'll just get like right up on you. It's like, ooh, you got to back up. And others, their space is larger. So with the patient, now 3 feet is important because I'm out of their reach usually. So that's probably why they've got 3 feet. But you also don't want them to feel boxed in or threatened. So 3 would be a minimum. I'm probably going to do 5 feet at least, where I'm out of their leg reach too. But and one of the reasons for making eye contact is so that you will notice if they are having any more behavior changes. Now, always with any behavioral patient or any patient, you have to do a good scene size up. With a behavioral patient, you're looking for some slightly different things. If you've got some stable little grandma that's having respiratory distress, I'm not so worried that she's got, a gun on the shelf in her room. But if you've got some freaked out person that is not of a normal mental status, I am concerned that they have a weapon in the box. So you may be looking for slightly different things. But do a good scene size up to make sure there are no weapons around that they could get access to. You're going to have to do your primary assessment anyway. If I can do a primary assessment pretty much from here if I need to. I mean, I can look here and see that you're breathing well, your skin tone is good, you're not having any respiratory distress. If a person's alert and oriented in this manner, you can be pretty sure that their primary assessment is going to be satisfactory. Now, if they're having some issues, they can have medical issues where they are having respiratory distress, they are having chest pain. I mean, if they're hypoxic from one of those events, then they may have some altered mental status and behavioral issues. And you may not be able to touch them to check their skin, but if you can, you want to do it. Perform a focused exam if you feel like that's appropriate. Oftentimes you're not able to touch these patients at all. So they may respond to you asking them questions, but don't be surprised if they won't let you touch them. Get as good a history as you can. What are you looking for in gathering history?
Anyone is before.
Do what?
Past psychiatric disorder and medications.
Yeah, how's the history gonna help you right now with history of present illness? I mean, you're looking to see if you can identify, is this acute onset, or something weird's happening, or they have this long history of, behavioral issues, or is this a medical issue that we can fix? So you're really just trying to find the root of the cause through your history. You want to do this? Some of the things you're going to be looking for besides how's your patient acting, what's their appearance? Are they well kept? Are they clean? Are they dirty? Does it look like they're well cared for? Or do they look like they're malnourished, they're not eating right, maybe that hypoglycemia or something of that sort. So you want to recognize their situation. Watch for unusual speech patterns. I think we kind of talked about these just a minute ago. As they're as you ask them questions like, tell me what's going on with you today. Like, it's really important with these patients, as with all patients, that you ask open-ended questions. Get them to talk to you. What's going on today? So tell me why you feel that way. What's going on that's led you to this? What are you going to do about this? What are your plans? How do you think this happened? Whatever. And that way you can follow their train of thought. Are they tracking in a normal manner? I just lost my husband. Well, how does that make you feel? Well, I'm really depressed. I don't want to be alive anymore. I don't want to be here if he's not here. Does that sound unusual or irrational? No. But on the other side, you could get somebody with these off-the-wall things, I lost my husband. I think I'm going to climb on the Empire State Building and shoot everybody. It's going to fire a really big gun. So that would not be normal. That would not be rational. So that would concern me more than, the lady saying she wants to kill herself. Self-destruct, it would concern me, but that didn't make sense. You know what I meant. Self-destructive behavior. Anybody that would hurt themselves would hurt you. So if they're telling you they want to hurt themselves or kill themselves, then I want to know how you're going to do it. And they usually have a plan. They've got a plan of how they're going to do it. Then there's a much greater chance they're going to follow through. And sometimes they'll say, oh, you don't want to ask them, like you're putting thoughts in their mind. You're not going to tell them anything they hadn't already thought of. If they're saying I'm going to kill myself. They're really going to do it. They've thought about it. And then I said, well, how are you going to do it? I've saved up, 500 pills I'm going to take. Really? Where are they? What are they? Where'd you get them? Or I've got a gun. You ever used a gun before? No. Okay. Well, let me help you with that. Really, not really. I'm just telling you, that's not funny. But the more information you can find out, it's going to give you a better idea of is this a serious threat or not. Sometimes it's just attention seeking, but if they've got a plan, they've worked out the details, it's the real thing. So you want to be alert to that. Of course, any violence or aggressive behavior, once you see that, if you don't have law enforcement there, you better have them by this time. But with all of your behavioral emergency calls, you want to have law enforcement. So in a lot of cases, they should respond with you. A lot of areas, they respond ahead of you, and they will call. But usually the dispatchers know with behavioral emergencies to send law enforcement. Patient care. Of course, if they have anything that's going to kill them, any life-threatening issues, you want to manage those. And sometimes that can be difficult. If they've cut themselves, even if the weapon's not around, they may be bleeding and they don't want you to touch them. So if they don't want you to touch them, even though they're bleeding, what are you going to do? Wrestle them down? Not without help, I'm not. Yeah. I did have a patient years ago that was having some type of behavioral emergency. I never found out what it was, but she had a really large knife, and she had been trying to kill herself, and she had cut herself all over. And we walked in her home. It was a mobile home. And there was blood everywhere, like they'd been slaughtering pigs in there. She had cut here and here and here. She was cut all over. And she was behaving so irrationally. It took probably 8 or 9 of us to hold her down. And I was real mean then, and my partner says, grab her hair. Well, I grabbed her hair. And he goes, no, grab her hair. And he meant run it all the way up like this and grab her head here so you could control her head. And he was 100% right. Grabbing here doesn't do anything, but grabbing here from the back I was able to pull her head back. She was trying to bite people, you know, and she was slinging blood everywhere. It was very, very disturbing, but she was going to bleed to death. She had cut herself that bad. So we had to, for her own, you know, preservation, we had to restrain her. And it's the hardest thing I've ever done. It was a real experience. There's blood everywhere. But anyway, you're going to have to treat life-threatening problems. I already said that. I think I mentioned this the other day. If they're having hallucinations, do we talk about that in here? Was it somewhere else? Okay. You know, you don't play along with it. They say, oh, I've got spiders crawling all over me. You say, oh, here, let me get those for you. You don't really do that. You say, I understand that, you know, you see those. I don't see any, but I understand that you do. That's what they tell you to say. Anyway, you'll hear some pretty bizarre things out there. Many times, getting a family member involved or friends, somebody that's familiar with their situation, they may be a big help to you as you try to calm the patient down or talk them into going to the emergency department with you. These are the patients that you always want to have your restraints close at hand. You want to consider the plan of how you would restrain them if you needed to. Hopefully you won't need to, but be prepared to do that in case you do. Suicide. I mentioned some of these a couple minutes ago. With a patient who is suicidal, many times they're substance abusers. They frequently have had a recent emotional trauma. It may be something like they lost a spouse, but you know, in the teenage years, sometimes it's so-and-so quit talking to me. You know, or I got a pimple or something. Yeah, my boyfriend broke up with me, something like that. So it's shocking that a person would kill themselves over something like that. Depression. Age. What do you think this means in this little diagram? Yeah, we see a spike in the teenage years, but then again also in the elderly. I mentioned they usually have a plan. If you ask them, if they really plan on going through with it, they're going to have a plan. One of the things that you will notice when you're getting history from family members, I'm speaking specifically of this sudden improvement. Say you've got a patient who's been depressed, you know, they've been thinking about committing suicide, they just can't go on, this kind of stuff. And all of a sudden the family reports, they were a lot better. They just got better, and you know, we thought everything was okay. And then they try to kill themselves. It's almost like they've reached that point where I'm going to do it. And they feel free. I've made a plan. I've got the means. Soon, I'm going to be free, and all this is going to be over. So that's one of the things you're looking for, too. They've had a sudden improvement in their mental status. They may be actually looking forward to a suicide. Suicide is the 8th leading cause of death, and it's rising. I think these figures are probably 4 or 5 years old that this is based on. But just over the course of that time, it has risen significantly. It's the 3rd leading cause of death in 15 to 24-year-olds. What do you think the leading cause of death is? Accidents, certainly. Probably car accidents. And we're seeing a lot more of the geriatric population. You know, people are living longer than they ever have. 60 or 75 years ago, I mean, if they lived to 60, they felt really old. Now, good Lord, Tim's mother is 92 or 3 or something. My grandmother passed away, she was 96. God. I heard a lot of them. But, you know, if you've spent 50 or 60 years with a spouse and all of a sudden they're gone, it's like very depressing. So, yeah, we're seeing a rise in that age group. So when you're doing your patient assessment, try to identify if the patient has any risk factors. You know, what's going on with them? Do they have severe stress in their life? Any large emotional upset? Are they depressed? Are they in the age group? Are they drug or alcohol abusers? We see it much higher then. Have they threatened suicide before? You know, they say, well, yeah, it's just attention getting. They tried suicide. You know, from time to time you're going to come across patients that you know it was just a call for help. They didn't intend to die, but they overdid it and they actually died from it. That's awful. They have a plan. They attempted it before. So these are things you're going to want to find out when you're getting your history. Okay, it's important that you establish a good dialogue with the patient if at all possible. You don't want to argue with them. That just makes it worse. If they say they want to kill themselves, then you just get as much information as you can about it. Sometimes you may have the opportunity to talk with the patient to get them to accept some help rather than, stab themselves or shoot themselves or something. So sometimes you can stand there and get them the assistance that they need. But scene safety is going to be at the top of the list. Your personal safety, your crew's safety. So at any time if you feel like it's not safe, you need to withdraw and turn that over to law enforcement. They have ways of restraining the patient without hurting them permanently. You're going to try to do your physical exam. Of course, you want to try to transport the patient. If it's not possible, it's not possible to do an exam. Just like, several weeks ago we talked about if you have a patient that all you can do is manage their airway, you never get any vital signs, well, then you never do. On your documentation, if your patient wouldn't allow you to touch them, then you just document the patient refused to allow me to touch them, so this is what I did. That's okay. And you want to constantly reassess their mental status. Is there any way to know if this patient, your patient maybe has taken a bunch of pills or not? That mean they took it? I had a family one time that swore up and down that girl tried to kill herself. She took a bunch of pills. And the girl swears up and down, I didn't take any pills. Nope, I didn't take any pills. Who do you believe? Would you expect her to be symptomatic? Not yet. Probably not. It may be an hour or two before she's symptomatic. So yeah, you just don't know. Could you leave that patient if she refused?
Yeah.
It depends on her age.
Well, her age, yeah.
Her family's there. How's that?
There's a lot of stress, but usually if she's of age.
Say she's 21.
Yeah.
And her husband called and said she tried to kill herself. She took all these pills.
I guess all you can do is wait for her to go unconscious and then apply soap.
So you're just gonna sit around there for hours?
Have
No.
call it.
You just say call back if she becomes.
Call the police and do tell them what?
Have a husband talk to them and maybe let them know. 'Cause you can
See who's lying? Somebody's lying.
If the woman wants
She
to die,
took
then
no
let her
idea.
die.
Thanks for
Or
her.
like a code 13 or something, if they threaten with suicide threat, then you can mandatory transport the officer.
She said, I didn't take anything. I'm not trying to kill myself. He said she said. What do you think, John?
Well, she's got to alter mental status. She was wanting my help.
Yeah.
Why
She's
is she-
If she's alert and oriented, and you feel like she has the capacity to refuse, of course, you have to do all those other things, part of the refusal, right? If she wants to refuse, she's got to know, well, if you really did take these pills, this is what's going to happen. You're going to die, or whatever. And you're just going to fall asleep and stop breathing, and that's what's going to happen. If you change your mind, you call us back. You may talk to the ER physician. He'll ask her, and she'll say, I didn't take anything. And he says, yes, you did.
And try and ask the husband what makes him think that she took it and see if he has any proof that he does and try to be started.
That's a hard thing to prove.
Does she have any history of psychiatric illness?
Yeah, that would be stuff you want to find out, certainly. But is it going to alter? If she's alert and oriented, and she answers all of your questions, and you feel like she's competent, then you have to let her sign and go. Now, and you can tell her husband, if she goes unconscious, or she gets uptunded, or she gets altered mental status, we're just around the corner. But as long as she's alert and oriented, you can't force her. And she may well have taken those pills. That's her prerogative.
Have you had that happen?
Yeah. It's kind of interesting. But yeah, if they're alert and oriented, they got to sign off. Now, what if he calls you back and she's unconscious, now what? Implied consent, yeah. Unless she's got a DNR or something, which she probably wouldn't have. Okay, your patient is a 23-year-old male. His girlfriend called 911 after a domestic dispute. He's uncooperative and refusing treatment. The girlfriend reports that he is depressed and suicidal. He owns a gun and has threatened to shoot himself. Okay. I'm leaving the house. Can you treat this patient if he did not call? Does he have altered mental status?
It says uncooperative, it's not altered mental status.
I didn't take those pills, and I'm not going to the hospital with you. Is that uncooperative?
Yeah. But with that type of thing, we'll definitely call law enforcement because she's willing to hurt herself and she doesn't want him to. There's some likelihood to kill her.
Well, it's a domestic dispute, they would have been on some long before we would have.
If nobody called. Yeah, law enforcement certainly. Can you treat this patient if he did not call? Well, does it say he's hurt? He's depressed and suicidal. What might you do?
Ask him, you can ask him some questions.
Yeah, try to talk to him. See if he'll tell you really what's going on. I mean, he might own up to the whole thing. Should you believe his girlfriend? Does this patient need treatment or transport?
It depends.
Not yet.
Can you treat and transport this patient against his will?
No, he's 23 years old.
Not a piece of work.
Just because he's depressed, you know. Now, if law enforcement gets there and they feel like his behavior is particularly hostile and they're concerned that, you know, he might hurt her, then they operate under different rules than we do. They may have the prerogative to take him in, but as far as healthcare providers, we can't force that on them. They've still got, you know, the ability to refuse there. It's a tough one. What should you do? Call law enforcement. They're not already there. Okay. Clues to whether you're going to a hostile environment or hostile patients. Listen to the dispatch information. There may be bystanders or people around, you know, when you pull up and they're saying, oh, that guy in there, he's, you know, throwing things against the wall. We can hear it all the way down the street. You know, look what your patient's presentation is. You know, if he's, you know, back in the corner crouched down in a chair, you know, with his head all down and stuff, kind of in a fetal position, not too scary. You know, if he's standing up with his hands on his hips and, you know, all puffed up like my cat gets, you know, when the dog comes into the yard, then you know you've got a problem there. Did y'all visualize that? My cat doesn't have a lot of hair, but boy, he stands it up. He's trouble. I mentioned earlier in the semester that with all patients, make sure you have mapped out your escape plan. 99.9% of the time you don't need it, but sometimes out of the clear blue, you're going to feel threatened and you're going to wish you'd planned your way out. So every room you come in, every house you come into, as you're walking in, you're thinking about how you're going to get out. As you approach your patient, you know, think about if I had to make a quick retreat, what am I going to do? I think I told you I always carry in my airway box, you know, and I plant it right in front of the patient. Of course, I can use it to set stuff on and that kind of thing, but if I got to go, I'm sacrificing that, and the patient's going to have to step over it. Or carry it with you. Be prepared to throw it if you need to, but always have something in the back of your mind as part of your escape plan. If your patient is real aggressive or hostile, you don't need to escalate that by threatening them or warning them or say, if you don't do this, then blank, 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 because they may just take you up on it. Stay alert for any type of weapons. What types of weapons could your patient have besides gun, knife?
Any object,
Anything they can grab. Yeah. Me too.
there are more deaths by hammer in the U.S. every year than 10 years of guns.
Do what? They've killed more people with hammers, is that what you said?
Yeah, there are more murders done by hammers and baseball bats than any
Yeah,
done by
I'll
guns.
bet. I'd like to have one of those. Hammers. Carry one around with me.
That's what Mama used to carry
A
around.
hammer?
Instead of a gun, she carried a hammer.
If you grab me, I'm going to hammer you to death.
Pretty much.
Ensure safety, calm your patient down. A lot of this stuff is redundant. Try to do a thorough assessment if you can. If they're hostile or aggressive, it's probably not going to happen. Be prepared to restrain your patient. In this case, if law enforcement can't get there, and if you're working in one of these rural areas, which I did at one time, it may be 30 or 45 minutes before law enforcement can get there. So you may call for a backup crew if you've got just more hands on deck. Sometimes you're better off. But if they're hostile, aggressive, and law enforcement can't get there, I'm just exiting. So that's where you'll find me. Take the truck somewhere. Do a good scene size up, request additional help. Seek advice from med control if you need to. You know, call them. Ultimately, your response is dependent on what they want you to do a lot of times. So they may be able to give you some help there. With a hostile patient, I don't know, but call them because that's what it says. Watch for sudden behavior changes and then reassess your patient. We always talk about considering restraint. Anytime you restrain a patient, you have to have orders. Just like giving your medications, at all levels, a nurse has to have orders. We have to have orders. In nursing homes, they have to have orders to restrain a patient. And I think it's probably good. With EMS, kind of what we go by is if you need to restrain, if you foresee that you may have to restrain a patient, then have your partner step back outside and go ahead and call for some orders or some recommendations, some advice. But on short notice, sometimes you may have to restrain them. In that case, you restrain them and then you call in as soon as possible and say, hey, this is what we had. We've restrained the patient. Will you give us orders for that? And they'll say yes. You know, when you're talking about your own personal safety, sometimes you may have to do that. Reasonable force and restraint. This is something that you guys usually will ask about. You can use reasonable force. That means enough to protect yourself, and in case of restraining your patient, you may do that. But reasonable force, that doesn't mean if the guy pisses you off, you can beat his face in. Okay? I know you want to, but you can't do it. Keep the patient from injuring themselves or others, which would include you or me. Now, if the patient is 5'2" and weighs 110 pounds, and you're 6'5" and you weigh 300, you don't need to beat them to a pulp. You should be able to restrain them like I restrain my cat. I just hold it by the scruff of the neck, out away from me where they can't scratch me. So they're going to look at the size, the relative size of the parties to determine if you use reasonable. And then whatever their behavior is, they have to be clearly out of line and clearly a threat to you or others for you to use reasonable force. If you have to punch them in the nose, you better explain why you had to punch them in the nose. And then, of course, we'll look at the available methods of restraint. You need to be very careful when restraining a patient. You need to use something that won't harm them. I mentioned, I think, posy restraints. They're like little lamb's wool things with leather and belt around there, where you would twist that around and then you may attach it to your stretcher, or you may, the best way is to attach them to a long spine board. That way you've got all those straps, plus you've got your posy restraints you can use. But there's a lot of different ones, but make sure you know how to use them, because they're a little bit more complicated than you think sometimes. You think, oh, I'll just wrap this around tight. And if it weren't for the fact that I've seen patients get out of those little tight things before, unfortunately, I know that they're sometimes, if you don't apply them correctly, your patient's going to get out. And are they mad then? Oh, they're like, if they were mad before, they are really mad that you've restrained them. So make sure you know how to use it. And then once you make the decision to use it, then you better get on it and use it. What about positioning a patient when you're restraining them? If you hog tie your patient, or you bring them up, up like this, or you restrain them face down, or one case up north, they zip the guy in a body bag. It's never going to happen. As a means of restraint. Not so good. But you've got to make sure they can breathe. You've got to protect their airway. So when you restrain them, don't ever restrain them face down. You just can't monitor the airway. But that does prevent them from spitting on you or biting you and things of that sort. And, of course, as long as if they're face down, that impulse on your part to hold their face in the pillow is very strong. So don't leave yourself with that temptation. Restrain them face up, all right?
We just need more rooms like that for like police dealing with people.
Okay, he looks like such a nice man. Some systems do not allow restraint without police or medical control orders. I can tell you pretty much nationally, you got to have med control in order to restrain a patient. Now, I said you can do it after the fact. If you have to do it in an emergent situation, you just call in and you say, we had to restrain the patient, you know, he was whatever. Like the crazy woman with the knife. Never attempt to restrain without proper legal authority or sufficient assistance. You and me not going to restrain that wild man. I don't care how big we are. It's not going to happen. If they're on, you know, drugs or they got some psychiatric issue going on, they could probably slay everybody in here. You know, so make sure you've got sufficient assistance for that. Make a plan. Make sure everybody knows what you're going to do. You can't just like rush a patient and hope everybody does whatever it is you think they should do. Make sure everybody knows what their job is and then respond very quickly. One person will talk to the patient, hopefully maintain that eye contact with them, can talk them down, calm them down, and you should have at least 4 people, 1 for every limb, because if you've got a patient who is unusually strong due to drugs or something, you're lucky if 1 person can hold 1 limb. Always restrain in the supine position. Always face up. Supine means the same thing. You're responsible for your patient's airway, so make sure that even when they're laying on their back, you know, when they're supine, can they have an airway issue? Yeah, they could be frothing. They could be bringing up a lot of mucus and fluid. They could have bitten their tongue. They could be bleeding, whatever. So you're going to still have to secure that. The best way to manage a patient that's spitting on you is to put a mask on them, a surgical mask. Now, this doesn't mean put a non-rebreather over their face and not turn the oxygen on. That's not what that means. I mean, just a light surgical mask so they can breathe through there. I know I'm not putting any ideas into y'all's heads. Y'all are envisioning all this, right? Okay. Make sure you reassess them and make sure their airway is adequate, and then you document this. Documentation is extremely important for these patients. Okay, we got a few conditions we're going to talk about. Excited delirium. This is going to be a psychotic disorder. Extremely agitated or psychotic behavior during a struggle, followed by cessation of struggling, respiratory arrest, and death. And we see this with drugs sometimes. They're so extremely agitated. They have super strength, and you think they're going to beat somebody to death. You restrain them, and within just a very few minutes, they've gone into arrest and died. And it's not because you've restrained them inappropriately or in the wrong way.
This is one of the guys said, one of the guys that was with Friday responded to that shooting in University Heights.
Yeah.
He said one of them, he was unconscious, and he said he just all of a sudden jumped up, punched him in the face, lay down and died.
Yeah, that's exactly what we're talking about.
Oh my gosh.
Yeah, it's usually drug-induced. Now, a patient may be hyperthermic and shouting incoherently. Remember we talked about some of the drugs that can cause this? Cocaine, come on y'all, amphetamines, methamphetamines. That's when you see this the most, where the heart rate is 300. It's just so tachycardic. Their blood pressure goes up, their temperature goes up. And once your brain starts heating up like that, you can't even think anymore. That's where you get this this excited delirium, and they have superhuman strength. And you end up taking them down if you can manage that. And it's not uncommon for them to, just out of the blue, then they just stop breathing and die. Drug intoxication, psychiatric illnesses, central nervous system stimulants. These are really scary patients. Unusual strength and endurance. They have a very high tolerance for pain. These are the guys that are hit with the taser repeatedly, and they're still running down the street with all this stuff, you know, dangling off of them. They look like Christmas trees. Very highly agitated, very hostile, frenzied, bizarre behavior. Their skin, if you get close enough to touch them, it's going to be very hot. They're hyperthermic. They're diaphoretic until, you know, they sweat it all off. But this comes on fairly quickly, so they probably have not gotten dehydrated yet. Unusual speech, shouting, screaming, hollering, doesn't make any sense. Positional asphyxia, that's a term I want you to be familiar with. Positional asphyxia, that means that you have restrained them in such a way that they can't breathe. That used to be a big problem. We've pounded it for so long now that we don't see it that frequently anymore. But however you restrain them, make sure that if they stop breathing, you didn't cause it. Okay? If they had excited delirium, they stopped breathing, what are you going to do? Yeah, you're not just going to go sayonara, hate it for you, shouldn't do drugs. What are you going to do? Yeah, you may suction, you're going to start bagging them. You know, put in an OPA, you're going to start bagging them. Do, you know, CPR if that's what it takes. You'll treat them like any other patient. Now, this says transport to the appropriate facility. You have to be very careful about where you transport psychiatric patients. I know in the Mobile area we had one hospital that had, you know, a psych floor. So most of your psych patients went there, but they have to have a diagnosis first before they're transferred there. So you can't just take a patient and say, oh, they're a behavioral emergency, we're going to take them to XYZ hospital. No, you take them to the closest hospital unless the patient or family requests something else. You don't just take them 20 miles out of the way because they have a psych ward. That's important that you recognize that. Any hospital has the ability to do an assessment on the patient, get a psych consult, a diagnosis, and then have them transferred. So don't feel like you have to take them to a psych place. Now, if they've got trauma, they're going to the trauma center. You know, you're going to treat them like any other patient. Because honestly, what do you think the percentage of patients that calls come out as psych calls or behavioral emergencies turn out to be bona fide psychiatric issues versus a trauma or medical?
At the best, half.
Yeah, at the best, half. So you start taking this guy with a drug overdose to a psychiatric hospital, or somebody with hypoglycemia, and you're driving them 20 miles out of the way to a psychiatric ward, you're going to get in some serious trouble. So very frequently, these behavioral emergencies, you don't know the cause of it. So you're going to take them to the closest hospital, or the closest, or what the family requests.
EMT has a special room for that, I found out.
For the psych patients.
Number 9.
Number 9. And then, of course, follow your local protocols. Your physician medical director for your service may give you specific directions on how to manage your psych patients, and you would follow that. Patients will be stabilized and evaluated, then transferred to the appropriate facility. So just know that. Okay, consent, we talked about that. You got to make sure if they are alert and oriented, you feel like they have the capacity to make an informed decision, then you have to honor that. You're really putting yourself out there. Laws typically allow providers to treat and transport patients against their will if a danger to themselves or others, which can be very challenging to figure out. Okay, sexual misconduct. You have to be careful when restraining a patient. If I've got a patient that's restrained in the back of the ambulance, I've got a rider with me. I'm going to take somebody else with me. If that guy gets out, you know, the ambulance is moving 60, I don't want to jump out the back. I'd rather have some means of protecting myself, like with another person. Sexual misconduct, and here they're talking about if somebody's restrained, but I just want to throw something in here too, that men particularly, you need to be careful when you're transporting a young female. If they have any kind of an altered mental status, I'd probably get a female to ride in there. And then you drive, or, you know, get a female crew if you can do that, just to protect yourself. You know, as long as you're going to provide them with equal, adequate care, you know, the same as you would provide, it's just a safety issue. Does that make sense? Yeah. So with altered mental status, try to have the same sex provider, if possible, in the back. It's not always possible, it's not always the case, but you know, if you get any creepy feeling about it, like I was working with a guy one time, and we worked where we traded off. This day he ran all the calls, next hour ran all the calls, and we responded to teenage girl, I can't remember what her deal was, but my partner was male, was about to climb up in the back with the girl. She was probably 14 or 15, and the mother says, "We're not going to let him ride in the back. The door's closed with her." And, you know, what do you do? I was very offended by that. But, you know, in that circumstance, it was better to just swap. You know, not make a scene about it. Because even if nothing happened, I trusted my partner implicitly. But it's all it takes is that girl to say, "Well, we were back there and blah, 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 blah." So it's just not worth it. And I'm not saying that you should always have same-sex providers. No, never. Just if you get that little inkling that there's an issue there, or if you have an altered mental status.
Are there cameras in that?
Not usually. Do they?
That would help.
They're
solve that
coming.
problem.
I mean, it's not a big problem, but just that I've experienced that a couple of times where it was a little, I don't like that. I just want to mention that to you. Have third-party witness present at all times on scene and during transport, you know, for your behavioral patients. You know, if it's, you know, some 65-year-old lady and she's, you know, depressed or something, then certainly not. But you know what I'm talking about. You'll just kind of get that feeling that, you know, I think I'm going to get somebody else to ride this. And that's okay. Review scene safety, especially with your potentially violent patients. You need to be kind and understanding and patient and caring, non-judgmental. Always look to see if there's a medical or trauma cause for the altered mental status or the aberrant behavior. Plan to be on scene for an extended amount of time if that's what you need to do. I've been on scene for a couple of hours before, so you just put everything else on the shelf. You're paid by the hour. You're not paid by the number of patients. So in these circumstances, just make sure you call med control or call dispatch, tell them that you're going to be on scene and that you'll call them when you're clear. Safety, yeah. Treat your psychiatric behavioral patients as you would any other patient, meaning what's going to be your primary concern? A, B, C. Yeah. So what if they're having some type of, you know, break with reality? It's still A, B, C's. Try to rule out physical causes. A lot of stuff is redundant, isn't it? What can you do when scene size that reveals it's too dangerous to approach the patient? Yeah, you want to extricate yourself. You know, if you've gone in, you want to come out. But if you're pulling up and you can tell that's an issue, then you want to get yourself out of sight of the scene. You know, if you come up and you've got a call for some strange behavior at the fraternity house, you drive up and there are a bunch of people out front drinking and milling around and, you know, looking weird in groups or something, then I'm probably going to drive around the corner. I'm going to call and say, you know, we're going to need law enforcement to respond here first. And then as soon as they get there, they'll call you in. They'll say they've got the scene safe or it's safe for you to come on in. So your safety is important, most important. What factors help you assess the patient's risk for suicide? What kind of things are you looking for? Or what? Do they have a plan? Have they done it before? Do they have a means to do it? What? No access?
History.
Yeah, history. Are they under a lot of stress? What's that stress, you know? Or what's going on with them that could lead them to that point? That's our classroom. Okay, do you have any questions about that? Y'all are super silent.